Good afternoon, and welcome to the City Club of Portland's Friday Forum. Today is Friday the 13th of July, and I welcome you to the state's premier civic affairs event. I'm Pat McCormick, president of the City Club, and I'd like to welcome members and guests alike, those of you who join us here today in the Governor Hotel, and those of you listening on OPB Radio or watching on Portland Community Media's CityNet 30. Today, our panel will discuss the local and national impact of the Supreme Court's recent decision on the Affordable Care Act. But first, some announcements. City Club's corporate and media partners are essential to the vitality and sustainability of the club. I'd like to thank our generous media partners, including Oregon Business Magazine. We'd also like to extend our deep appreciation to Friday Forum's corporate sponsors, ESCO, Morel Inc., Northwest Natural, and Schwabe Williamson and Wyatt. We are grateful for your support and your commitment to the City Club's mission. If your company or firm would like to support City Club's mission through sponsorship, please contact the friendly staff in the back of the room or call the City Club office. Our Agra Committee, which is sponsored by Sterling Savings Bank and Tonkin Torp, will be discussing Alexis de Tocqueville's iconic book, Democracy in America, on Thursday, July 19th. We invite you to join them for the discussion. You can learn more from the City Club website, www.pdxcityclub.org. As always, we will be welcoming City Club members to the microphone after the forum for a question and answer session with our speakers. In addition, we invite all of our audience members to locate the index cards that are on your tables, write your questions on them during the forum, and hold them up when I ask. City Club staff will collect these cards, which I will then read from the microphone during the question and answer period. We are sure you will come up with some great questions for today's speakers. And now our program. Though the Supreme Court held up most of President Obama's signature legislation, the Affordable Care Act, many questions still loom. Today, our panel of experts will predict how the health law will impact health systems, employers, and consumers, and what it will mean for Oregon's health care reform efforts as elements of the law go into effect over the next 18 months. Our first speaker today is Melanie Curtis. Melanie is the managing partner of Stoll Reeves Seattle office, where she concentrates her practice primarily on health and welfare benefits. She is a member of the employee benefits section of her firm's benefits, tax, and wealth management group. In December 2011, Washington Governor Christine Gregoire appointed Melanie to the first governing board of the Washington Health Benefits Exchange. Our second speaker is Dr. Chuck Kilo, the Chief Medical Officer at Oregon Health and Sciences University. There, his responsibilities include performance improvement, clinical risk management, and regulatory and medical affairs. He was previously a vice president at the Institute for Healthcare Improvement, where he ran the idealized design of Clinical Office Practices Initiative, which sparked a national focus on medical practice improvement and redesign. Today's final speaker, Laura Etherton, is the Healthcare and Public Policy Analyst for the U.S. Public Interest Research Group, which is the Federation of State PIRGs. In her role, she supports the work of state PIRG directors and advocates across the country in their work to establish state-level pro-consumer policies to cut costs, improve care, and improve health. She also leads the organization's work on healthcare and public health at the federal level. And with that, please help me welcome today's first speaker, Melanie Curtis. Melanie?
Good afternoon. We have all the answers to all your questions. On June 26th, Chief Justice John Roberts demonstrated the wisdom of our nation's founders, stating, "Nothing can be said to be certain but death and taxes." I never thought I'd start out a talk like that. The court majorities ruled that while sitting at home doing nothing, and nothing in this context equals not purchasing health insurance, may be bad for your health, it's not commerce, and commerce cannot regulate your inactivity. Congress can, however, tax it, which means, as we all well know by now, and I expect why you're all here, that the Patient Protection and Affordable Care Act, as amended by the Health Care and Education Reconciliation Act of 2010, is constitutional. I don't know about you all, but the morning of the 26th, I was on the SCOTUS blog watching. Some of you were watching some news programs and got some conflicting information that morning. And I was happy I was on SCOTUS blog because I might have had a heart attack. And taking a step back for a moment, we all were saying before this happened that if it's found to be constitutional, we just march on, it's business as usual for employer-sponsored plans, for insurers, for those who provide services to plans, and let the politics do what they're going to do. And in some respects, that's where we are. However, most often law follows society, and on rare occasions it must lead. And it's usually when there are unresolved questions that involve moral and practical issues that impact all of us. And at first glance, we might not think this case is a big deal, but some of us think that actually this was a watershed moment. And arguably, this case could be as important as something like Brown versus Board of Education, Korematsu versus the U.S., or Marbury versus Madison. It's significant, and it's significant because it's going to impact how we pay for healthcare services and the federal government's ability to create and impact future reforms. It may have just been limited. We don't know for sure, time will tell, but this is something to pay attention to. I would also encourage you all to read this opinion. I ran screaming from constitutional law in law school, thought I'd never have to deal with it again in my life, and here I am. But I read this opinion, and if you are in and around healthcare at all, it's very well written, it's easy to read, and it puts everything together in one place. You learn about how much the tax is going to be. You learn about how much the Medicaid expansion, how much it's going to cost the federal government to do this Medicaid expansion. It's worth the time and effort. So what were the issues? We all well know. There was the constitutionality of two provisions. One, the requirement that most Americans maintain minimum essential health coverage or pay a tax penalty, the so-called individual mandate. And two, the grant of permission to the Secretary of the Department of Health and Human Services to withdraw all the Medicaid funding provided to a specific state if that state chooses not to expand Medicaid to certain individuals, certain additional individuals. This is the so-called Medicaid expansion. With respect to the individual mandate, the Act amended the Internal Revenue Code to provide that individuals who are not exempt and who do not receive health insurance through an employer or government program, they must satisfy this requirement to have coverage by purchasing insurance from a private insurance company, through an exchange, if you will. Beginning in 2014, those who don't comply with the mandate must make what's called a shared responsibility penalty, payment or penalty to the federal government. The payment is calculated as a percentage of household income subject to a floor and ceiling. In 2016, for example, the penalty will be 2.5% of an individual's household income, but no less than $695 and no more than the average yearly premium for insurance that covers 60% of the cost of 10 specified services, which are essential health benefits. I know that's a mouthful. It's a mouthful to read and it's a mouthful to write, but that's what it is. The court struck down the individual mandate as an improper use of Congress's authority under the Commerce Clause, which generally provides Congress broad authority to regulate interstate commerce and activities affecting commerce, but upheld in a 5-4 decision as a valid use of Congress's taxing power. Specifically, the court said the Act's requirements that certain individuals pay a financial penalty for not obtaining health insurance may be reasonably characterized as a tax. Because the Constitution permits such a tax, it is not our role to forbid it or to pass upon its wisdom or fairness. there's a lot of quotes like that throughout the opinion, which is why I would say it's worth reading. What's interesting, however, is that while the court concluded that the individual mandate is a tax for determining whether it's constitutional under the Congress's taxing power, it concluded that the individual mandate is not a tax because Congress didn't call it a tax. They called it a penalty for purposes of the Federal Anti-Injunction Act, which says that you can't bring suit to enjoin or to stop a tax from being assessed until it's actually been assessed. This was the kick the can down the road scenario that we all were hearing about, that if they decided the Anti-Injunction Act applied, we'd be doing this all over again in 2014 when the first taxes would be assessed. So that's what happened with the individual mandate. With respect to the Medicaid provisions, under current rules, states are required to cover only certain individuals. States typically do not provide coverage to childless adults, and they have flexibility as to the level of coverage that are provided to these certain categories of individuals. The Act expanded the scope of the Medicaid program and increased the number of individuals that a state must cover. Medicaid coverage would be expanded by 2014 to nearly all individuals with incomes up to 133% of the federal poverty level, whereas many states now cover adults with children only if their income is considered lower and do not cover childless adults at all, generally. For 2012, 133% of the federal poverty level for an individual is an annual income of $14,856, and for a family of four, it's $30,657. Under this expansion, the federal government would provide a significant subsidies to states for providing the coverage. 100% of this expansion would be covered by the federal government through 2016, and then it gradually reduces to 90% thereafter. The Congressional Budget Office says that this increases the federal government's Medicaid spending by $100 billion per year, nearly 40% above current levels. The court concluded that the Medicaid expansion exceeded Congress's authority under the Constitution's spending power, and it was unconstitutional, because it would permit the Secretary of Health and Human Services to withdraw all Medicaid funding, not just the expansion. The threatened loss of, in some instances, as much as 10% of a state's overall budget would have left the states with little or no choice but to agree to the expansion. The court said you can't do it. However, the court stated that the constitutional violation is fully remedied by giving the states a choice as to whether to participate or not. And I think my colleagues here on the panel are going to talk a little bit about more of what that could mean for Oregon. There are far-reaching implications for this. The politics around this have already begun. Many states have already said, we're not going to participate, we're not going to do the expansion, we think it's going to cost us more money. Do those kinds of things mean, for those states that don't do it, what's going to happen to those who could be eligible for it? Are they all going to move to Oregon, Washington, and California? Perhaps. So what are some of the implications? I'm going to talk in a minute about the more sort of tactical things that we and the employer plan setting are worrying about, and on the insurance side are worrying about. It's what we've been worrying about and dealing with since 2010. We are still worrying about, still dealing with it, and we are begging for more regulations because we need them to go about the business of getting ready to comply with all of what we need to comply with this year, next year, and in 2014. But one sort of interesting thing to think about is taking a step back from the more sort of practical considerations, that in order for a tax to be valid, it can't be punitive in nature. That's what they said in the case. The court said that the shared responsibility penalty did not even approach being punitive in nature, and when you think about the amount of this tax, that's true. The whole point of this individual mandate was to get young, healthy people into the insurance system so that we could spread around the risk and all be covered at a lower price. Well, young, healthy people may very well engage in an economic analysis and say, gosh, that's only going to cost me $1,000 a year. Coverage is going to cost me $600 a month. I don't need it now because I'm not sick. I'm going to pay the tax, and I'm going to wait till I get sick to get the insurance. And commentators have said that penalty needs to be much higher. But the minute it goes much higher, we're then potentially opening up to another challenge, another constitutional challenge, that it's a penalty and not a tax. Again, I've talked about if states opt out of Medicaid, what does that mean for the states that stay in? And there are other issues that I think, our other panelists will discuss. So now to the more sort of tactical things. This cloud of legal uncertainty has been lifted. So there are lots of interesting issues still for employers. For those of you in representing employers or in employer organizations, we're going to be reporting coverage on Form W-2. We are going to be issuing food labeling summaries of benefits. We call them the food label summaries. It's a summary of benefits where you put everything you need to know front and back on 4 pages, and that's coming to a plan near you really soon this year. There's going to be this Patient-Centered Outcomes Research Institute fee. All plans and insurers are going to be paying into this trust fund where we're going to study this for a while. $2,500 limit on flexible spending accounts coming in 2013. And then there are the exchanges. We are all expecting to be up and running and functioning very well and ready to accept open enrollment on October 1st of 2013. These exchanges, this is so complicated, and there is so much technology in all of this. There's been a lot of press about states not being able to be up and running and ready for it. Washington and Oregon are way ahead of the pack, and I'm telling you, it is still a lot for us to get done in a very short period of time. There are people working around the clock to get ready to have these exchanges up and running. So what happened 2 days ago? The House passed repeal of Obamacare. They called it repeal of Obamacare Act by a vote of 244 to 185. 5 Democrats joined the entire Republican caucus voting for the measure. Very unlikely to be considered in the Democratic-controlled Senate. The House passed a similar measure in 2011. This has come to the House floor 40 times since 2010. It's going to continue. We can expect other efforts to thwart it, repealing selected provisions, withholding funding. What's been repealed so far, by the way, are items that funded the Affordable Care Act. Given the flexibility, we may see more flexibility to get the exchanges up and running at a later date. Nothing's going to happen until after November the 6th. And shall we talk about November the 6th for a moment? All roads lead to November 6th. We're all going to be doing what we need to be doing between now and then to comply with our obligations under the law as it stands today. If there's a Republican president and a Democratic-controlled Senate and a Republican House, odds are there's not a lot that can really change. It would take a full-scale change of Republican House, Senate, and President to probably repeal this fully. So I'm done, and I'm going to pass. But we'll hang around for questions. Turn it over to Tim.
Thank you. My name is Chuck Kylo, and I appreciate Pat's introduction. And I am the Chief Medical Officer at OHSU. Many of you know me because I started a primary care group in town about 12 years ago called Greenfield Health, and I know I see many Greenfield patients out there, so I did that for about 10 years before transitioning to OHSU about 2 years ago. So I can speak to this a little bit from both the private practices perspective and from the large academic medical center perspective. I appreciate being able to spend some time with the City Club. I do listen to the City Club. It's mostly Friday nights while I'm washing dishes at about 7 o'clock at night. But I appreciate the fact that OPB does broadcast it at that time so I can listen to it. I have not read the entire bill, and I apologize for that. It is a good cure for insomnia, so you can keep it at the bedside. It is very, very complicated, and I think it's unfortunate that it's very complicated, but I think that reflects the political atmosphere that we live in. We certainly would all, I think, like to wipe the slate clean and start over and create something that's much simpler. And maybe at some point we can create a political process that would allow us to have such an intelligent and well-intended conversation as that. For the time being, it doesn't seem like we can quite get there. It's not clear to me that most people really understand the depth of the problem that is U.S. healthcare, the amount of waste in it, and that waste you pay for, the amount of inefficiencies in what we do, the duplication of services, the problem of the poor healthcare quality that we have, despite spending twice as much money as almost every other industrialized country. These are really very profound problems, and I think they have a very detrimental economic effect on our country. And I wish we could focus on those things as opposed to the politics behind those things, which I think is really quite unfortunate. But those things really are important. And I think they're important because healthcare is having an increasingly negative effect on our economy. You can't spend 17% of your GDP on healthcare when you're not getting the product that you should be getting at half of the price and have that be good for employers. And so I think that irrespective of one's political persuasion, it is urgent that we get our arms around healthcare and that we get everybody covered. And I think getting everybody covered is really important as well. An unhealthy society is an expensive society, period. And while some people might not like the fact that we should cover everybody, it is an economically intelligent thing to do. So we ought to argue for that, if only for self-interest, right? It's the same way we would argue for education. An uneducated society is a very expensive, non-productive society, and we need to view health and healthcare as being in the very similar light. So I think we should be advocating for those things again, irrespective of where we are along the political spectrum. And fortunately, OHSU has. And I just want to read to you 5 of the 8 principles that OHSU has been articulating going back to 2008, so well before the ACA was passed and was even a part of the discussion. And so you'll see the synergy in our thinking. I'm only going to read 5 of them because I think they're the 5 most applicable ones. But we support universal access to a defined set of healthcare services for all children and adults that is paid for in ways that are not exclusively linked to employment. So universal access is critical. Another thing that we need to do to change our mindset is if you are employed, you have health care. Therefore, it is a tax. You may not want to think of it as a tax, but you don't have any choice as to whether you're going to pay it or not, right? Therefore, it's a tax. So we should just call it what it is. You're just paying a tax through your employer in a brutally expensive way to pay that tax into a very inefficient delivery system. So the employer-sponsored model, at its core, doesn't make sense. It might have made sense after World War II when it was sort of started, but it doesn't make sense in the year 2012. Number 2, we believe that a defined set of healthcare services in a universal access framework should include all healthcare services that are demonstrably beneficial, including tertiary and quaternary healthcare, in order to guarantee equal access to care and to prevent a continuum of inequities in the current system which ties care delivery to economic status. And so core to this is a defined set of healthcare services that are evidence-based. The ACA helps to fund PCORI, the Patient-Centered Outcomes Research Institute, which is really critical because we continue to do things that do not add value. Every day we do tests and procedures in abundance to people who have insurance that have no demonstrable benefit, right? It is possible that half the things that have ever been done to you in healthcare, whether it's a simple blood test or otherwise, did not need to be done and was wasteful. And that's what PCORI is about, and the Act helps to fund that. Number 3, we believe that geographically well-distributed healthcare workforce, accurately mirroring the capacity and diversity of the population it serves, is critical to ensuring long-term quality and access in Oregon. Funding for recruiting, educating, and keeping workforce skills current is also critical. Further, healthcare reform must find ways to utilize all providers to the full benefit and extent of their education and training. So the appropriate distribution of resources is a really critical part of this. As you know, the Act talks about accountable care organizations and other things like that. It enables those kinds of functions, if you know anything about ACOs, accountable care organizations. In Oregon, we have called them, while you can apply to be an ACO nationally with CMS, we have called what we're doing in Medicaid or OHP CCOs, as you know, coordinated care organizations. And you may have some questions about those. I'll touch on those just briefly in a second. Number 4, our 4th principle. We support an aggressive focus on preventive health care to improve quality and reduce costs, including promotion of and reward of healthy lifestyles. And number 5, we believe that the long-term viability of universal access will depend on the full and equitable participation of all healthcare providers and systems. The opting out by a provider or healthcare system should not disadvantage those electing to participate. So we talk about the equitable distribution of our capacity and the rational distribution of our capacity. And in fact, that's what CCOs in Oregon are intended to be. And so whether we like it or not, irrespective of what political persuasion you are, the ACA helps us to begin to move towards these things. It is more complicated than it needs to be, and I think that's unfortunate, but that is the political climate that we're in. It would be good if we were focused on solutions as opposed to just criticizing the act without any solution to back up the criticism. And I think that's really the problem that the Republican Party has. And I think it's a very terribly unfortunate position to be in. And so I think that's a problem, because we have a good part of our political persuasion that is not really actively engaged in the problem. They're actively engaged in criticizing it. And that, in fact, looks a lot like what doctors do, right? We are superb at sitting back and complaining about what everybody's doing to us, but we're lousy at creating really good solutions to how we make things better. And so the Republicans must have taken lessons from the American Medical Association or something along those lines. Now, I'm just going to touch really briefly on this thing called ACOs, Accountable Care Organizations. Again, they got translated into CCOs in Oregon, Coordinated Care Organizations. So the term ACOs was brought about, 4 or 5 years ago by a guy, Elliot Fisher. He is a professor at Dartmouth. And Elliot was sitting around, and he was saying to himself, how do we make U.S. healthcare a lot more like Sweden? All right? Now you can't say that in public, right? And the reason you can't say that in public is because despite the fact that Sweden is a long-standing, thriving democracy, you would get accused of being socialist if you said that, all right? As unfortunate that is the political persuasion, the political environment that we live in. And yet this is what Elliot was thinking. In Sweden, they fund health care at the level of the county. The whole country is broken up into counties. And the county decides how they're going to rationally distribute those resources. They have to make trade-offs. They have to make hard decisions. How much towards end of life? What kind of end of life? How much towards home care? How much towards pharmacy? They have to make that decision. They benchmark very aggressively county to county, very aggressively. One county is not going to go build a hospital in another county. They don't do that, right? They don't duplicate resources like that. But they do aggressively benchmark against each other for the sake of continual improvement. And that's very important. Now, he said, we can't be that. We can't talk about being Sweden. So he came up with this concept of an accountable care organization. And that's sort of where it came from. How do we get health systems to take accountability for populations of individuals? Now, the issue is, with Sweden, the population of individuals is geographically defined. You got to care for everybody in the county. And in the U.S., because we can't have that geographic distribution, health systems get to define what population they're responsible for. So as you can see with ACOs rolling out, if you, the health system, define what population you want to take responsibility for, well, there's all kinds of people you don't want responsibility for, even though you should, right? Most community health systems are much more interested in going out, finding insured patients in somebody else's area that they can attract than they are interested in taking care of all of the people in their community. And that's very unfortunate. But our system allows that to happen. We ignore those with needs at our doorstep so we can go find those who can pay at somebody else's doorstep. And then we do all kinds of crazy things to try to attract them from that system to my system, right? And guess how much you pay for that? An enormous amount, an enormous amount. It's wasteful, it's silly, it is irrational. And therein that defines the U.S. health system, unfortunately. Thank you. So in Oregon, we have these things called CCOs, thanks to the governor. Let's take this concept and let's apply it in Medicaid to geographies, right? Let's create a framework. Let providers in those communities and insurers, providers and insurers come together in those communities, create organizations that will take care of a geographically defined group of OHP patients, right, of Medicaid patients. And as, you know, with the ACA, as that expands, and we take care of those. And what that's encouraged, you might say in Roseburg, where there's one health system and a group of doctors, they could do that because, you know, there's only one hospital, and you know, whereas in Portland, obviously, we've got all the competing health systems. And what that has done is that it has encouraged us to come together. And as you know, I think you know, the CCO in the Portland metropolitan area is called the Tri-County Medicaid Collaborative. And it's done just that. It's gotten all the health systems at the table, and I think the depth of productive discussions that we haven't had, as far as I could tell, in decades. And people aren't backing out, and we're having the hard conversations, and that's really important for us to do. And so I think therein lies part of the key benefit here. It has encouraged that kind of community collaboration. We're a long way from making the decisions that we need to make. We're a long way from having a rational distribution of resources. But at least people are in the room and they're not backing out of the room. And so I think that's really important. So from my perspective, what the Act has done is it has enabled this kind of conversation to go on. There are states that are resisting. I think that's unfortunate. And the states that aren't resisting, it has created a lot of very productive discussion and activity. Just the beginning. We're just scratching the surface. We have a long way to go. But therein, I think, lies the benefit of it. And so much of the Act has put things in place like the insurance exchange and other things like that the states that are really far along, I don't think we're going to go back on it anyway. In part, you know, our funding crises are so critical, we have to do things to get cost out of the system and to get people covered. And so thanks to visionary governors and visionary states like Oregon and Governor Kitzhaber, I think we're fortunate to have that. So I'm going to stop now. We'll move on to Laura, and then we'll take questions. Thank you very much.
Hello. My name is Laura Etherton. I'm the U.S. PIRG Policy Analyst on Healthcare and Public Health. U.S. PIRG is the National Federation of State PIRGs like OSPIRG here in Oregon. And I want to thank you for the opportunity to speak today and to share with you the perspective of a consumer organization. Today I'll touch a little on what the ruling means for consumers right now, but I hope to spend more time focusing on where we go from here, how we can tackle the problem of rising costs, not by cutting care, not by raising deductibles, but by cutting the waste and focusing on prevention. Again, I work with U.S. PIRG now. I think it's been about 2 weeks. Before that, I worked with OSPIRG, Oregon State Public Interest Research Group. I did that for about 17 years, and I'll focus most of my remarks about Oregon, of course. So a little bit about OSPIRG. We're a nonprofit, nonpartisan consumer organization with a 40-year history of standing up for the public interest. Our healthcare program really grew out of our consumer protection program, and so it focuses mostly on what consumers are facing: rising costs, concerns about quality and safety. OSPIRG has a set of staff of researchers and advocates who work to get practical solutions implemented at the state and federal level. And of course, we also reach out very broadly to the public. Some of you may have heard about our canvas. You're probably familiar with people coming door to door to ask you to get involved. This year, I think it's surprising for a lot of folks to realize just how much we actually talk to people. This year alone, we'll have face-to-face conversations about key public policy issues with over 80,000 Oregonians across the state. That's from La Pine to Coos Bay, from Beaverton to Pendleton, from Phoenix to Astoria, all across the state. So I think that grounds us in what real consumers are facing. It prevents people like me who can kind of wonk out on healthcare from getting too out of touch about what people are really facing on the ground. So getting to the topic at hand, what does the Supreme Court mean? The Supreme Court ruling mean for consumers right now? What we find is many consumers breathed a sigh of relief when the Supreme Court upheld the Affordable Care Act. Young adults can stay on their parents' plan until they're 26. Insurance companies will still have to pay at least 80% of that premium. They're actually going to have to devote that to care as opposed to administration and marketing. Insurance companies can't go back to the days of denying coverage to sick children. And in 2014, the days of insurance companies denying coverage to anyone because of pre-existing conditions will be history. That's important not just for those consumers, but for the entire market to shift more so insurance companies will compete not on how to avoid insuring sick people, but compete on how to help sick people get better. Now we need to take the next steps to tackle healthcare costs and focus on solving the problems that Chuck did a great job of laying out. And whether you love the healthcare law, whether you hate it, I think we can all agree that healthcare costs more than it should. We've got problems with quality, and we have to do more to make sure consumers get a fair deal. This year, the Milliman Medical Index reported that annual healthcare costs for a typical family of 4 exceeded $20,000 a year for the first time. I can believe it. We hear about these rising costs all the time and how they're impacting families and small businesses. For the couple who runs a small shop in McMinnville, it's open 7 days a week, their $1,600 a month health insurance policy, it's holding them back from hiring an additional employee so they can actually take a day off a week. For the man in Waldport who had hoped to retire this year from his manual labor job with the railroad, it's the high cost of health care that's forcing him to keep working and stay on his health plan until he can qualify for Medicare. For the owner of a construction company here in Portland, it's the fact that coverage for his 4 employees hit $48,000 this year. It makes him wonder if they can afford offering coverage. It's time to move forward on the next steps to make sure health reform delivers lower costs and better quality. The good news is Oregon began working on these very solutions before the national health care law was passed. The Affordable Care Act helps, and we have to press ahead. Here's my list of the top 3 areas where Oregon can make real improvements, where we can succeed in moving the ball forward in the year ahead. The first one is making sure insurance companies continue to meet high standards to justify raising rates on consumers and small businesses. Thanks to new rules that went into effect in 2010, Oregon has put more than $37 million back in the pockets of consumers and small businesses by reining in excessive premium increases. But much more can be done to encourage insurance companies to do everything they can to address the underlying causes of rising costs. Again, not by raising deductibles, not by cutting access to care, but by cutting the waste and focusing on care that is effective and that helps people get healthy from the start as opposed to paying on the back end. The second very significant thing that Oregon can do to move forward is to make Oregon's health insurance exchange great. It is a lot of work. As Melanie outlined, there's a lot of work to make sure that the exchanges all across the country are up and running and are fantastic, beginning in October of next year. But this is one of our best shots to get it right on healthcare. And done right, the exchange will be a competitive health insurance marketplace where consumers and businesses can join together to get a better deal on coverage. In the year ahead, just here in Oregon, exchange officials will make really important decisions on how this works. What standards will insurance companies need to meet in order for their plans to qualify to be offered on the exchange? What tools will consumers have to compare plans apples to apples based not just on price, but on quality, on providers, on their network, on customer service rankings? And how will the exchange learn from successes? For example, the Healthy Kids program. How will the exchange learn from those successes to maximize enrollment, to reach out to people and encourage them to participate? Finally, Oregon needs to lead the way on lowering costs while improving care. Governor Kitzhaber's plan that Chuck mentioned to transform the healthcare system, starting with the Oregon Health Plan, holds tremendous promise. Coordinated care organizations are being launched right now to deliver better coordinated care that focus on prevention so each patient stays their healthiest. And in the year ahead, it will be critical for the public to stay involved to ensure CCOs meet this promise, so they meet those benchmarks and make continual improvements moving forward. On the national stage in the year ahead, we can expect healthcare to continue to be a political football. When it comes to talking about healthcare, it will be awfully tempting for many of us to become armchair political pundits, myself included. But I hope that in Oregon we can set a different example, that we can remember when we talk about healthcare, we are talking about the lives of our neighbors, and that we do what we've always done here. We roll up our sleeves and we get to work solving the problem. Thank you.
Thank you for the informative and interesting discussion, and we look forward to more of it in the questions. And now, if you have a written question on an index card, please hold it up high so that City Club staff can collect it. Thank you very much. The first question for our speaker, as always, will be from our Friday Forum host this week, Rob Aldisert. Rob has practiced law for 20 years and serves as managing partner at Perkins Coie. He recently chaired the club's PERS study committee and is leading the advocacy efforts for the study's recommendations. Rob?
Thank you, Pat. I had a couple of good questions on some technical issues that you've already answered. Thank you very much. But I did hear Chuck say that our employer-provided insurance system is irrational. And I'm wondering whether you're advocating for a single-payer system, and if so, why? Or what are you advocating for if you're not?
Well, whether we call it a single-payer system or some sort of unified financing system, maybe it's a matter of semantics. But if the government collects the money and is a fiscal intermediary for the distribution of that money, either to geographic areas or through insurers, to providers, then we don't necessarily have to call that a single-payer system. It could be a single fiscal intermediary, which in and of itself would take a stunning amount of cost out of healthcare. And the German system is like that. Germany has insurance companies still. They're highly regulated. The government collects the money. They based on various things. They distribute it to insurers, and then the insurers do what they do with it and pay providers. And so there are there are mechanisms such that we don't have the argument about government-controlled health care and all that sort of things, which we don't have, and in fact we really never have had. And this act doesn't create that either. And so I think we need to think openly about that. And when you start to engage people in how much costs are built into the current system, how much wasteful costs that have nothing to do with health or health care, and that we could be using those monies for much more productive purposes, that's when we at least open up the conversation across the political aisle. And I just fundamentally have never understood why we can't have that kind of intelligent conversation, why it has to always degrade into what it degrades into, which is so harmful to our communities and to our society. And so I think there's ways of framing it that really uses the government as a fiscal intermediary.
We will now take questions from the floor. As always, we invite members to the microphone to ask their question. Asking questions at the Friday Forum microphone is a privilege of City Club membership. Before asking your question, please identify yourself as a City Club member and ask your question in 30 seconds or less. If I flash this question mark card, it means please wrap up your question. Also, I will read at least one audience member question from the index cards. Barbara?
B.J. Seymour, City Club member. If the object of insurance has been to spread the risks so that everybody is involved and those who are not sick can help meet the cost for those who are, and if this act is so revolutionary, why do we need insurance companies? Why couldn't we just have the government cover everybody without the intermediary?
Okay, I'll try this one. Yeah, I know. I'll be out of a job. I'm speaking against interest. It's okay. This is compromise legislation. We have a system of insurance. That's how people have their coverage paid for today, and this could be seen as an intermediary step between what we have today and what Dr. Kelo was just talking about. They worked with the system we had with the system we have, which is a system of insurance, and they needed to get more people. They needed to get more people into the system to make it more affordable. This could be seen as a step, not necessarily an end game, but your question is a good one, and it's very hard to answer. It didn't reform insurance. When we think about these exchanges, everything in the exchanges are based on a fee-for-service model. All of the reporting that goes back and forth between the exchanges and the federal government and the employer and the individual for purposes of the penalties or the taxes, if you will, and the subsidies that people get are based on being able to actually figure out how much something costs. Well, how much something costs and how we figure that out today is based on a fee-for-service insurance model. So I know it's a long answer, and I'm not really answering your question, but I'm trying.
Hi, Joyce Demonin, City Club member. Thank you so much for a great program. I was very impressed. I know a lot of the healthcare law rhetoric was around healthcare rationing versus the conversation around evidence-based medicine. Is evidence-based medicine part of the healthcare law, and is it health rationing?
So what is evidence-based medicine? Because I'm not sure people really understand the term. But everybody understands science, right? And in healthcare, because we should not be doing things to people for which we do not have proof that it's beneficial, right? The things that we do to you, we should know that they're going to help you, or we shouldn't do them, okay? And so evidence-based medicine is about where is the evidence for the things that we do to you. Is there evidence that doing a prostate-specific antigen test, a PSA test, in a male of a certain age helps extend that individual's life? right? If there is evidence for that, and actually we can do that at a reasonable cost, then we should do that as a society. If there's not evidence for that, or if it's too expensive, for example, if that test leads to improved mortality, but it costs $10 million per person, we're probably not going to do that at a social level, right? At a societal level. So evidence-based medicine is about helping us to define what works. Does it really work? What PCORI couldn't do was to include costs, which is crazy that we can't talk about costs, right? But what we really want to do is say, not only is there evidence that it works, but how much does it cost if it works? Because we need to make rational trade-offs in what we spend our money on. If we spend our money, if we have $1 million, because we do not have unlimited resources. I don't think we have unlimited resources. Last time I checked, we didn't. So if we have $1 million, we can either spend it on this one thing or this one person, or we can spend it on this bunch of things and these bunch of people. And we need a rational way of making those decisions. And so evidence-based medicine is really about that. Let's define better what works and the processes for making it work. We also need to layer on top of that something called cost effectiveness, right? How much does it cost to make that thing work?
Hi, I'm Sharon Robbins, City Club member. I've heard that the reason, or the biggest reason, that we need to repeal the ACA is to put healthcare choices and decisions back with patients and their doctors. But my health insurance dictates which doctor I can choose via out-of-network penalties, or maybe we should call those taxes. And my doctor has to ask insurer permission or pre-authorization for treatment modalities. So if we went back to pre-ACA, exactly how would I be able to work with my doctor to make my health care decisions?
Sure. I can try to take that one. There's not really anything that I read in the law, and I did read the law, that gets in between the patient and their primary care physician or their doctor or any of their providers. So in terms of that relationship between the patient and their provider, my reading of the law and of how it's being implemented is, in fact, it strengthens that. And one of the key ways that it strengthens it is actually what Chuck was just talking about, evidence-based medicine. The law doesn't, as Chuck rightly mentioned, say, okay, after we figure out what works, we're going to then make a decision about what you're allowed to have. What the law says is, let's figure out what works, and let's make sure patients and providers have the best information at their fingertips, and that they have that in an electronic format. So, for example, you go to one doctor and they, type information into your chart. You go to a different doctor. That different doctor has your information about you, and they also have information about those best practices. That's good. That's good to have that good information for you and your doctor. So, as we move forward, we may say, okay, if you're an insurance company, if you're a state trying to figure out how to use limited resources, what's the best way to design insurance products to get people the best care early on, so you prevent, conditions from getting worse and having to make more later. But in terms of the law itself, our analysis of the law is there's not a single thing in the Affordable Care Act that limits patient choice or that gets between a patient and their provider.
Let me read a question from the audience. Imagine for a moment that the Affordable Care Act is overturned in early 2013. What would be the impact on Oregon's healthcare plans?
I don't know that anybody really knows that, but I do know that both our governmental leaders, at least those in power right now, and our health system executives know that we're close to crisis mode and know that we need to do something. And it's not like we haven't known that for a long time. We have known that for a long time. And I think that the act has created the stimulus for us to move forward on it more aggressively and more thoughtfully. I don't know that there are a lot of things in the act that really can't be reversed at this time or would take a long, long time to reverse. So I think it's been been a good stimulus to get people at the table and to change the conversation, and I see that continuing.
Kurt Wavering, member. I know a person who is employed, makes a few dollars over a minimum wage, and her employer will pay 80% of any health insurance that she is able to get, which is not possible for her because of her income and, frankly, the difficulty of maneuvering in a system. So my question is, once the act is in 2014 or thereafter operative, what would the situation be for this person?
Sure. Without knowing the exact person's income and the different sources of the income, essentially in 2014, a couple of things will happen for that person. One is that they will be able to qualify potentially for tax credits to help them pay for coverage. And that will be very helpful. And that's if they make more than what they would need to qualify for Medicaid. It's possible that this person actually could qualify for Medicaid depending on their income, the number of hours they work, et cetera. They might qualify for Medicaid. They might be able to qualify for free or very low-cost care in either case. The other thing that will be helpful for the person is that, and this is also what makes the related issue of let's get a handle on healthcare costs important, is that if the person that you're talking about didn't qualify for Medicaid but did qualify for help through the exchange, and
it's 133% to 400% where the subsidy comes in. So it's above the Medicaid threshold of 133, and between 133 and 400 is where this tax subsidy comes in.
It's essentially a sliding scale according to your income. But what's important is that the mandate or the tax will not apply to people if, once all of that is figured in, paying for care would actually exceed 8% of their income. So the implementation of the law would essentially give this person potentially a lot of help in affording health care. And if healthcare costs go crazy, that person will most likely be held harmless and not required to be paid a penalty.
One more thing on that question, because it's a good question and a good case study, if you will. Another case, I was in a cab last week, going to the airport, chit-chatting with the cab driver. Guy used to work at one of our technology companies, got laid off in a downsizing. He and his wife have 2 kids. His wife is a part-time student. They have no health insurance. Healthcare is, I think Laura might have said it, healthcare is the #1 cause of personal bankruptcy in the country. Healthcare is the #1 cause of what kind of health system would drive people into personal bankruptcy? I mean, irrespective of your political persuasion, does that make sense? Now, if you think about personal bankruptcy, because this person, one bad illness, if she's not buying her insurance, one bad illness puts her family into personal bankruptcy. What are the long-term health consequences of that? Healthcare is the #1 cause of personal bankruptcy. Healthcare consumes 16% of the average family's disposable income. It is a figure unimaginable to anybody sitting in this room. 16% of the disposable income of the average American family goes to health care, right? So we've got to solve this problem. It is harming our families. It's harming the health of our community. Health care is harming the health of our community in very substantial ways, right? So we got to get our arms around this problem, and we have to do so in positive, productive ways together.
Last question.
Carl Twombly, member. Wouldn't it be helpful to reduce costs if we required health insurance to be nonprofit and clinics and hospitals to be nonprofit and doctors to be paid on a salary rather than a piecemeal basis which seems to incentivize increasing the numbers of patients they see and the number of tests and other procedures performed?
Yeah, I mean, perhaps, I would say, but not so simple as that. In the Pacific Northwest, I don't know if there are any for-profits in Washington, but we have no for-profit health systems in Oregon. Some of the national providers, some of the national insurers here are for-profit, but most of our local insurers are non-for-profit. So we basically have the situation that you said. A lot of our health systems have employed physicians. It might be a part of the solution, but it's certainly not all of the solution. It doesn't get at the duplication of resources, and it doesn't get at lots of the other things that drive utilization in unproductive ways.
We have run out of time for further questions, and we'll have to stop for the day. Join us next week for a look at Oregon's energy future. And as we close for today, please join me in offering a sincere thanks to today's speaker, Melanie Curtis, Chuck Kylo, and Laura Etherton. We are adjourned.